Let's begin, Dr. Roth.
Okay, thank you. Good afternoon, everyone. Welcome to the Department of Medicine Grand Rounds today, which I'm pleased is the Jacques Bourgonnier Medicine Grand Rounds. Just a quick background on this. Jacques Bourgonnier, after he passed, had this lectureship established by friends, colleagues, and family members really to honor him and the contributions he made to the University of Miami. He had come here in about 1976 and soon thereafter became the chief of nephrology, a position he held here for almost 25 years, which was remarkable. During that time, he built the division and really set the foundation for nephrology here at to allow it to become what it has become today as the Katz Family Division of Nephrology with continued growth in science and clinical care. Jacques was a real classic academician. He valued research, he valued education and patient care, and he emphasized all of those for those who worked in his division. And I think really the most important thing that I'd like people to know about Jacques is that he treated people with enormous respect. He was a gentleman all the time, no matter what was happening around him. And it's for that reason that this lectureship exists and has been established. I'm thrilled with the guest speaker we have today, and I will let her be introduced at this time. Thank you again for being here.
Good afternoon, everyone. It is my greatest pleasure to introduce Dr. Connie Rhee. Dr. Rhee is a practicing nephrologist, physician scientist, and tenured associate professor of medicine and public health at the University of California, Irvine. She pursued her clinical nephrology fellowship and postdoctoral research training at the combined Brigham and Women's Hospital and Mass Gen Nephrology Fellowship Program, and also completed a Master of Science in Epidemiology degree program at the Harvard School of Public Health. Dr. Rhee joined the University of California Irvine Division of Nephrology as faculty in 2013, and she currently serves as the Department of Medicine Vice Chair of Clinical Research, as well as the Division of Nephrology, Hypertension, and Kidney Transplantations, Director of Clinical and Translational Research, Director of Dialysis, Quality Improvement, Associate Director of Outpatient Hemodialysis, and Acting Associate Chief. Dr. Rhee's research has been centered on metabolic and endocrine interventions in kidney disease, as well as the conservative management of advanced chronic kidney disease, with 2 active NIH grants as the principal investigators in these areas. She has been supported by multiple NIH, NKF, and ATA grants throughout these years, and her lecture today is entitled Hypothyroidism in Chronic Kidney Disease, Physiologic Adaptation or Pathologic Entity. Please join me in welcoming Dr. Rhee for today.
I'd like to thank Dr. Roth and Dr. Ocampo, also Dr. Weiss and Dr. Coronary for their beautiful introduction and very kind invitation to join you today. It is truly an honor to be able to serve as your Dr. Jacques Bourgonnier Medical Grand Rounds lecturer. I've been very excited for this meeting for a number of months now. And as Dr. Ocampo mentioned, I'll be speaking to you on hypothyroidism in CKD. Is this a physiologic adaptation or a pathologic entity? So these are my disclosures. And I first want to just express my tremendous gratitude to the University of Miami Department of Medicine and Division of Nephrology for the opportunity to join with you today. Dr. Jacques Bourgonnier has left a tremendous legacy at your institution, and most certainly under the leadership of experts such as Dr. Coronary, Dr. Roth, Dr. Weiss, and many others. The University of Miami has truly been an epicenter of scientific discovery, medical innovation, and clinical excellence. As a physician scientist whose research has been centered on endocrine and kidney diseases, you can imagine my excitement to be able to connect with you today, where University of Miami is a major hub of both thyroid disease and also kidney disease under Dr. Weiss, Dr. Pornorni, and Dr. Roth. And thank you all so much for this time today. So as mentioned, the major theme of my research for the past 14 years has been focused on the intersection between endocrinology, metabolism, and kidney disease. And I've been very grateful to work and learn from not only nephrologists, but also endocrinologists through the years. And we put together a number of resources to try to serve the medical community, including a textbook that was published a couple of years ago, a very recent Seminars in Nephrology special issue that we released last year. And if any of you have any interest in having access to these resources or in just collaboration, please do reach out to me. I believe in team science, and I think that's what makes, I think, us a better service to our patients and the healthcare community. So over the next 45 minutes, there are 4 main objectives I would like to cover. We are first going to review the epidemiology of hypothyroidism and CKD. We're then going to move to examining the mechanistic links between thyroid and kidney disease. We're then going to compare data on hypothyroidism and outcomes in the non-CKD and CKD populations, including plausible causal mechanisms for adverse cardiovascular and patient-centered outcomes. And then we'll close with discussing the risks and benefits of thyroid hormone replacement in hypothyroid CKD patients, which serves as the rationale for our NIH Thyroid HD trial. So in terms of the epidemiology, as many of you are well aware, hypothyroidism is a very common condition in the general population that is characterized by biochemical tests, which include an elevated TSH, which in conjunction with a low or normal free T4 indicate overt or subclinical hypothyroidism. And landmark data from NHANES-3 that is now 2 decades old show that as many as 10 million adults in the US are affected by this endocrine complication. And various cohorts suggest that up to 4 to 10% of the population have subclinical disease and up to 2% may have overt disease. Now, given that thyroid hormone receptors are present in nearly all tissues, if left untreated, hypothyroidism may have pervasive effects on most organ systems. It may lead to cardiovascular complications, neuropsychiatric disorders, hematologic issues, gastrointestinal problems, reproductive abnormalities, musculoskeletal complaints, and last but not least, it can lead to complications of the kidney. Indeed, large population-based studies have shown that there is a substantially higher prevalence of hypothyroidism in CKD. So this was a nationally representative cohort of 14,000 participants in NHANES, in which investigators showed that there was an increasingly higher prevalence of hypothyroidism with incrementally impaired kidney function, such that those with an eGFR of less than 45 had a nearly 5-fold higher prevalence compared to those with normal kidney function. These differences persisted even after accounting for age, sex, race, and ethnicity, with about half of cases due to subclinical disease. Our research group has also confirmed a strong relationship between low thyroid function and kidney disease. So in a study of over 450,000 US veterans from the National VA database, we found that for every 10-point decrement in eGFR, there was an 18% higher risk of hypothyroidism independent of patients' comorbidities, laboratory characteristics, and medications. And while there's been comparatively less data in the dialysis population, a number of cohorts have also confirmed a higher prevalence of hypothyroidism in hemodialysis and in peritoneal dialysis patients. However, in the clinical setting, there is likely under-recognition of disease because of hypothyroidism's symptom overlap with uremia, such as fatigue, cold intolerance, impaired cognition, and low physical function. Now, in terms of the interaction between thyroid and kidney disease, at this time, the mechanistic link between thyroid and kidney disease remains largely unclear. But experimental models have suggested that hypothyroidism adversely affects kidney size and structure. And in animal models, it's been shown that low thyroid function leads to decreased kidney to body weight ratio, a truncated tubular mass, as well as changes in the glomerular basement membrane architecture. In addition to these structural changes, it has also been suggested that hypothyroidism may lead to kidney dysfunction, with potential mechanisms including decreased cardiac output, alterations in intrarenal hemodynamics ensuing from decreased vasodilator synthesis and activity, abnormalities in the RAS system leading to impaired autoregulation of renal perfusion, and changes in chloride channel expression in the nephron leading to increased tubular glomerular feedback and decreased kidney function. Animal studies have also shown that low thyroid function leads to decreased single nephron GFR, a reduction in renal plasma flow, as well as decreased glomerular transcapillary hydrostatic pressure. And older human case series of very severely hypothyroid patients who underwent thyroidectomy showed that they had reduced renal plasma flow as well as GFR measured by creatinine-based estimating equations and gold standard isotopic scans. That was actually reversed with receipt of exogenous thyroid hormone replacement. However, more recent data also suggests that having even mildly impaired thyroid function may be a risk factor for developing de novo CKD. So this was a rigorous study that was conducted in a prospective cohort of over 100,000 patients in South Korea who had no underlying kidney disease at baseline. And routine thyroid functional tests showed that those who had higher TSHs in the highest quintile within the normal range actually had a 26% risk of having de novo CKD. And when they looked at continuous TSH levels as a restricted cubic spline, they saw a monotonic rise in the risk of having CKD up to a TSH level of about 3, above which risk plateaued. Our research has also demonstrated a relationship between both hypo and hyperthyroidism with developing incident CKD and CKD progression. So about 3 or 4 years ago, I developed a collaboration with United Healthcare using their National Optum Labs data set, which has been an incredibly rich resource for looking at nationally representative CKD patients. And with one of my mentees, we looked at over 4 million US adults who underwent thyroid functional tests and kidney function tests and found this association. But I also want to highlight that when we looked at TSH levels with finer gradations, we saw that higher TSHs, even in the high normal range, above a level of greater than 3, showed a potent relationship with incident CKD and CKD progression. And this level of greater than 3 is a threshold that we're going to continue to return to in many of our studies looking at adverse sequelae of thyroid dysfunction and kidney disease. As promising data, there has been some research showing that receipt of thyroid hormone replacement may actually mitigate the risk of CKD progression. So this was a well-done study looking at 309 adults with subclinical hypothyroidism and stage 2 to 4 CKD in an international cohort. And at baseline, 58% of patients were treated with thyroid hormone replacement and 42% were untreated. And after a mean follow-up of 3 years, it was found that those in the treated group had a slower decline in their kidney function compared to those who were treated. And while this delta of a point of 4 mils per, while this delta of a GFR of 4 over the course of 1 year may not seem like a sizable amount, we have to keep in mind that the formal definition of rapid CKD progression is actually a delta of more than 5 per year. Conversely, it has also been suggested that the uremic milieu or advanced CKD can also predispose to thyroid functional test abnormalities. So for example, in metabolic acidosis, we see alterations in T3, T4, and TSH that may be reversed with oral sodium citrate and sodium bicarbonate therapy. Selenium deficiency is very commonly observed in dialysis patients and may be a risk factor for exacerbation of autoimmune thyroid disease. Iodine retention is commonly seen in kidney disease patients because this is an element that is renally cleared, and having excess iodine may potentially predispose to hypothyroidism via the Wolff-Chaikoff effect, which we'll talk about in more detail in just a minute. Given that the vast majority of thyroid hormone is protein bound, heavy protein losses in nephrotic syndrome, as well as through the peritoneal effluent in PD patients, also may lead to total body thyroid hormone loss. And finally, non-thyroidal illness and malnutrition are common conditions seen in advanced CKD patients, which may also contribute to thyroid functional test abnormalities in this population. I'd like to pause here and talk in more detail about iodine excess as a potential risk factor for low thyroid function. So iodinated contrast media are one of the most commonly administered pharmaceutical agents worldwide, with 80 million doses annually prescribed. And in the past 2 decades, there has been a 400% increase and an 800% increase in the utilization of contrast-enhanced catheterizations and CT scans. On average, a single dose of iodinated contrast media confers 13,500 micrograms of free iodide, as well as 15 to 60 grams of bound iodide that may be liberated to free iodide in the body. And this is actually 90 to 400,000 times the daily recommended intake. Now, in normal kidney function, we do not have to worry because contrast media is rapidly excreted via glomerular filtration in unchanged form. However, in moderate to advanced kidney disease, this is substantially protracted. And furthermore, dialysis patients have disproportionate exposure to iodinated contrast media because of their perceived invulnerability to contrast nephropathy and because they frequently get cardiac catheterizations, fistulograms, and peripheral angiograms that have high iodinated contrast media content. Now, as many of you are well aware, iodide is actually an essential element for thyroid hormone synthesis. So this is a figure of a thyroid follicular cell in which we see iodide entering into the cell via a sodium iodide transporter on the basolateral aspect of the membrane. Iodine then diffuses to the apical side where it becomes oxidized and covalently bound to thyroglobulin in a process known as organification that is catalyzed by thyroid peroxidase. These thyroglobulin moieties then couple to bind T3 and T4 thyroid hormone, also catalyzed by thyroid peroxidase. However, if exposed to an excess of iodine, once again, patients may develop hypothyroidism via the Wolff-Chaikoff phenomenon. And although the underlying mechanism is not entirely clear, it has been suggested that exposure to excess iodine can lead to generation of iodolipids and iodolactones that can actually inhibit this organification and hormone synthesis process catalyzed by thyroid peroxidase. Conversely, being exposed to excess iodine can also lead to thyrotoxicosis or hyperthyroidism via the Iodide-Bezadov phenomenon by providing excess substrate for thyroid hormone synthesis. Now, for many years, there had actually been sparse data actually confirming a relationship between iodinated contrast media and thyroid disease in the general population. And many existing studies were actually limited by their inclusion of patients with pre-existing thyroid disease. So they were actually not looking at development of incident thyroid disease. Previous studies were also limited by their small sample size, their short-term follow-up, their restriction to neonatal or pediatric patients. And most importantly, there were no controlled studies. There were no studies actually comparing patients exposed to contrast and not exposed to contrast and seeing who went on to develop de novo thyroid disease. So when I was a postdoctoral fellow years ago at Brigham and Women's and Mass General Hospital with not a lot of funding, I fortunately had access to a very rich database called the Partners Healthcare Research Patient Data Registry. And this was just such a wonderful training vehicle for me at the time when I was studying epidemiology and biostatistics. And in this study, that was a case control design, we looked at adults who had at least 2 TSH measurements separated by 2 weeks to 2 years. And all patients had to have no evidence of pre-existing thyroid disease. Therefore, at baseline, all patients had to have had normal TSH, and we excluded patients who had evidence of pre-existing thyroid disease based on diagnosis codes, procedural codes, as well as medications. Now, using this nested case control design, at baseline, all patients had a normal TSH. So we defined our cases and controls according to patients' follow-up TSH. So hyperthyroid cases were those who developed a low TSH. Hypothyroid cases were those who developed a high TSH. And controls were those who maintained a normal follow-up TSH over time. And we matched our cases to controls on a number of different confounders such as age, sex, race, kidney function, the time between the baseline and follow-up TSH, as well as the data of the follow-up TSH. Our exposure of interest was a contrast-enhanced CT scan or a cardiac catheterization in the intervening interval between the baseline and the follow-up TSH. And as the preferred methodology for a nested case control design, we use an incidence density sampling approach. And to provide more information about this, essentially using this approach, a single patient can contribute multiple control intervals and up to 1 case interval for the analysis. So this figure illustrates the longitudinal experience of a hypothetical patient who by definition did not have any existing thyroid disease. And the patient started out with a normal TSH, was exposed to contrast, and then had a follow-up TSH that remained normal. So this became a control interval. 3 years later, the patient had another TSH test, but this TSH exceeded our 2-year interval, so was not eligible to contribute to the analysis. The patient then underwent another TSH test within 2 years that remained normal, so this became another control interval. And finally, the patient was exposed to contrast, developed a high TSH, and this was designated as a hypothyroid interval, and the patient was no longer eligible to contribute data to the analysis. So using this incident density sampling design, we ended up with 213 incident hypothyroid cases who are matched to over 700 controls. As you can look at their baseline characteristics, the patients were fairly well balanced, showing that the matching was successful. I do want to highlight that we had a low prevalence of kidney dysfunction because of very stringent eligibility criterion for our study. Conversely, we had 178 identified incident hyperthyroid cases who were matched to over 600 controls. And again, their baseline characteristics were well balanced, but we had a very low prevalence of kidney dysfunction because of our strict eligibility criteria. Now, in terms of our main findings, we found that exposure to contrast media from either cardiac catheterization or CT scan was associated with a higher risk of developing hyperthyroidism overall, as well as severe hyperthyroidism. There was a trend towards a significant association with hypothyroidism overall, and we did see a potent relationship with the risk of developing a severe hypothyroidism. And through collaborations with nephrology and endocrinology colleagues, we have confirmed these associations in other community-based cohorts and pediatric cohorts over time, but more research needs to be done. So in summary, there appears to be a bidirectional relationship between thyroid and kidney disease, although all the mechanistic underpinnings are still not entirely clear. This is an active area of research in my laboratory, and if any of you have any interest in further elucidating these knowledge gaps, please feel free to reach out to me for the opportunity to work together. So a question that I am often presented with is, why as a nephrologist do you care so much about thyroid dysfunction in kidney disease patients? And one of the very simple answers is that we know that thyroid dysfunction is an established risk factor for cardiovascular disease in the general population. So it may lead to systolic and diastolic dysfunction, as well as endothelial dysfunction, which in conjunction with hypertension and obesity and dyslipidemia may lead to accelerated atherosclerosis. Hypothyroidism may also lead to changes in cardiac ion channel expression, which can lead to prolongation of the QT interval, setting the stage for a malignant cardiac arrhythmia. As we've seen, hypothyroidism may be a risk factor for kidney dysfunction, which in and of itself is a risk factor for kidney disease. There has actually been data in both the general and CKD population that has shown that low thyroid function leads to decreased production of vascular calcification inhibitors, such as matrix GLA and clotho, that we'll talk about further. And in our CKD and dialysis patients at our institution, we have seen a number of cases of EPO-resistant anemia, as well as severe anemia requiring transfusions due to hypothyroidism that has been completely reversed by restoring patients' thyroid function. And finally, there has been emerging data showing that low thyroid function may predispose to an increased platelet size with more activating particles that can potentially lead to thrombosis. So in the general population, there has been a large body of literature looking at the relationship between subclinical hypothyroidism, cardiovascular disease, and death. And many of the studies have been mixed, but in a very rigorous study that was a landmark publication by the International Thyroid Studies Collaboration, they looked at 11 global prospective cohorts in a pooled analysis of 55,000 patients. And they showed that subclinical hypothyroid patients with a TSH level of greater than 10 had a higher risk of coronary heart disease events, and those with a TSH level of greater than 7 had a higher risk of coronary heart disease death. This thyroid studies collaboration also went on to look at the relationship between subclinical thyroid disease and the risk of heart failure. And in a pooled analysis of 6 prospective cohorts of over 25,000 patients, they also found that patients who had higher TSH levels and subclinical hypothyroidism with a threshold of 10 had a higher risk of heart failure events. When our group looked at the existing body of data, we noticed that there was a tendency towards positive associations in populations of high underlying cardiovascular risk, but null associations in studies of patients with average to low cardiovascular risk. So this prompted us to conduct a study looking at participants from NHANES who were stratified by having underlying heart failure. And very interestingly, we found that hypothyroidism was associated, hypothyroidism overall and subclinical hyperthyroidism were each associated with higher death risk in a non-CKD population in those with heart failure, but not in those without heart failure. And this bears particular relevance to our advanced CKD and ESRD population because by the time many of our patients arrive at end-stage renal disease, 70% will actually have structural heart problems. With collaboration with experts and expert collaborators and mentors in endocrinology, we've also found that in the non-CKD population, cardiovascular disease, a substantial part of the death that we see with subclinical disease and poor survival. So in terms of the CKD population, early studies of hypothyroidism and CKD actually hypothesize that thyroid hormone deficiency is actually a physiologic adaptation and a means to conserve metabolism in dialysis patients who are prone to hypercatabolism, malnutrition and protein energy wasting, as well as dialytic protein and amino acid losses. But in the past 15 years, there's actually been growing interest in hypothyroidism as an under-recognized and novel cardiovascular risk factor in CKD. So unfortunately, we know that ESRD patients have a 7 to 10-fold higher death risk compared to their non-ESRD counterparts, with half of deaths due to cardiovascular causes that are not wholly explained by traditional risk factors. And there has been growing data showing that low T3 and T4 levels are associated with adverse cardiovascular outcomes in the dialysis population. So for example, in a study that is now a decade old out of the Karolinska Institute, investigators showed that having persistently low T3 and T4 levels was associated with a higher risk of all-cause and cardiovascular death in a prospective hemodialysis cohort. But I do want to underscore that there are limitations in terms of looking at low T3 and low T4 to ascertain thyroid status in patients with advanced CKD and ESRD. First, the vast majority of T3 is actually derived from the peripheral conversion of T4 to T3 in organs outside of the thyroid. And this process is highly sensitive to malnutrition, as well as non-thyroidal illness, inflammation, high cortisol levels, and a number of medications that are very commonly observed in CKD. And it's proposed that actually low T3 may, in fact, be an indicator of malnutrition or illness in our advanced CKD and ESRD population. Second, as we discussed, the vast majority of thyroid hormone is protein bound. And routine assays that measure that active form of free T4 use indirect approaches that are actually protein hormone binding dependent. So in uremia or in illness states or with exposure to heparin and Lasix, this protein hormone binding is impaired and it can actually lead to spurious free T4 results. So to accurately ascertain free T4 status, we actually use direct free T4 assays leveraging equilibrium dialysis and tandem mass spec to more precisely measure free thyroxine in our dialysis patients. Conversely, TSH is actually the most sensitive and specific single biochemical thyroid metric in the general population because of its negative logarithmic association with T3 and T4. So in other words, having small changes in T3 and T4 can actually lead to exponential changes in TSH. I do want to mention that it has been suggested that there may be some alterations of TSH seen in kidney disease, such as reduced clearance, blunted response to TRH, reduced pulsatility, increased half-life, as well as impaired glycosylation leading to impaired function. However, these data are very limited, and this is most definitely a topic that needs further research and a potential collaboration. And as a refresher, in non-thyroidal illness, the pattern of thyroid functional tests we typically see is in mild illness, we initially see decrements in T3. As this progresses to moderate illness, we see reductions in T4. And it is not until patients actually arrive at severe critical illness that we see a decline in TSH. And so TSH is typically robust in non-thyroidal illness, although we can see a transient rise as patients are in recovery. So for a number of years, there had actually been a paucity of data examining thyroid status rigorously ascertained by TSH levels in the CKD and ESRD population. So when I was training back in Boston, I had the opportunity to look at their Partners Healthcare Data Registry, in which we looked at 2,700 dialysis patients at National Hospital and Brigham and Women's Hospital. And at baseline, we actually saw that 13% of the cohort had low thyroid function, and they had a worse survival compared to their spontaneously euthyroid counterparts. Now, our study was shortly followed by a publication by the 4D trial investigators shortly thereafter. So as you know, the 4D trial was a clinical trial of diabetic German dialysis patients. And in this study, the investigators found that baseline hypothyroidism was not associated with sudden cardiac death, nor with cardiovascular events, nor with all-cause death. But I do want to mention that only, or actually less than 2% of their cohort had hypothyroidism, so less than 20 patients. And both of these studies were limited by looking at a mixed incident and prevalent dialysis cohort who have very differential survival characteristics. Both of our studies had a limited examination of confounders, and both studies only looked at thyroid status defined at a single point in time when we know that thyroid function can fluctuate. So as a faculty member at UC Irvine, I was very grateful to have access to an amazing national dialysis database from DaVita, which is the second largest dialysis organization in the US, in which we looked at over 8,000 national incident hemodialysis patients. And of patients who had TSH tests that were measured, nearly a quarter had hypothyroidism. And so using two approaches, we looked at patients' thyroid function as they transitioned to dialysis, their baseline thyroid status. And we also looked at all of their repeated measures of thyroid function over time in time-dependent analyses. And these analyses essentially approximate long-term versus short-term relationships with thyroid status and outcomes. In both of these approaches, we saw that having hypothyroidism was associated with higher mortality risk. Again, we also looked at thyroid function using finer gradations of TSH, and also saw that having higher TSH levels of greater than 3 were associated with poor survival. And we found that these associations were robust across most subgroups of age, sex, race, and ethnicity. And to explore the hypothesis that hypothyroidism may potentially be a physiologic adaptation in patients who may have malnutrition and protein energy wasting, we also look at these associations across varying BMI categories. And very interestingly, in our time-dependent analyses, which are represented by the open circles, we saw stronger associations among patients with higher levels of BMI. And in our baseline analyses, represented by the closed circles, we actually saw that these relationships were aggregated in those with a BMI of less than or equal to 20, who we may actually consider as being undernourished in the dialysis population. We also had the opportunity to look at thyroid status in a national cohort of DaVita PD patients and saw that both hypo and hyperthyroidism were associated with higher death risk, as well as a disproportionate representation of thyroid disease in these cohorts. I do want to mention that the analyses I presented to date have looked at largely databases from electronic health records for which data was not collected for research purposes. And we don't know the reasons for which thyroid status was measured. And that could potentially lead to impaired generalizability if these patients have a higher pretest probability of having thyroid disease. So I had the wonderful privilege of being previously supported by an NIHK award, which allowed me to assemble a multi-center dialysis cohort in Southern California across 17 dialysis clinics, in which we looked at over 500 hemodialysis patients. Over time, with other funds, I've continued to grow this cohort, and we now have over 1,000 patients with a very rich data repository. And if any of you have interest in collaborating further with our data, please let me know. I'd be very excited. But in this early analysis of patients who underwent protocolized TSH tests every 6 months, we again found a high prevalence of underlying hypothyroidism. And we saw that higher TSH levels, even in the high normal range of greater than 2.5 to 3, were associated with a higher death risk compared to those with lower TSH levels. In the general population, we oftentimes think of thyroid disease as a condition that largely affects women more than men. Our research has suggested that there probably is equal predisposition. And one of the studies to highlight this was a publication that we had in US veterans that was in Mayo Clinic proceedings. I was really grateful that our article was actually selected as an editor's choice publication. And if you don't have time to read the paper, the editor-in-chief actually gave a brief synopsis on their website. And if you really don't have time, we have a 60-second synopsis on YouTube that you can listen to while you're washing the dishes or folding laundry. But I'll give you the very brief 20-second overview. So in this study of US veterans that was over 90% male, we saw a very high prevalence of low thyroid function. And we saw that both hypo and hyperthyroidism were each associated with higher death risk in this cohort of US veterans with stage 3 CKD. And once again, when we looked at more granular definitions of thyroid status, we saw that higher TSH levels, again, above this threshold of 3 that we returned to and again, was associated with higher death risk in this cohort. So I have been extremely fortunate and grateful to be mentored and coached and encouraged by mentors in endocrinology and in nephrology who have advised me to continue focusing in this area over the past 14 years, especially during times when I was not confident of whether I was doing high impact work. And so I think several years ago, when we had this editorial published about our article, it really encouraged me to continue to press forward in this area. And so these experts in endocrinology noted, overall, this study provides considerable food for thought. And the interesting results reported in the study will require careful consideration if we are to improve the health of our target CKD population. Subsequent studies should pursue TSH screening in patients with CKD, both to understand the magnitude of the problem and to allow for prospective evaluation. We need future research also examining other thyroid parameters. And finally, as this article demonstrated, there is much left to do if we are to understand and harness these new insights and to improve the lives of our patients with CKD. So this has been major motivation and inspiration to continue in this area. There's still a lot we have left to do. We can't do it alone. We believe in team science. And if any of you have interest in working together, please let me know. So one of the areas we're actually working on is trying to inform screening recommendations in the CKD population. So even in the general population, the guidelines are very mixed with respect to who should be screened. But I do want to highlight that the ACC and the AHA recommend screening of thyroid status in all patients with newly diagnosed heart failure. And when we consider that most of our dialysis patients actually have underlying structural heart disease, 70% of incident dialysis patients, essentially we should be screening all of our dialysis patients. But at this time, there is still a lack or absence of screening guidelines in the CKD population. Another area that we are actively working in is to understand the mechanisms by which survival may be compromised in dialysis patients and CKD patients with low thyroid function. I have been very fortunate to collaborate with Dr. Matt Budock, who is a world-renowned expert in coronary artery calcification and a cardiologist at the Harvard-UCLA Medical Center. And we recently completed a study in which we looked at over 100 dialysis patients who underwent thyroid functional testing as well as cardiac CT scan. And in this study, we actually found that higher TSH levels, once again, above a threshold of 3, were associated with having a higher coronary artery calcification score. So once again, it has been shown that having low thyroid hormone levels leads to lower production of matrix GLA and Klotho as vascular calcification inhibitors. We've also looked at poor endothelial function as a mechanistic link between thyroid status and cardiovascular disease and kidney disease. And so we have been working with a really novel a tool that measures endothelial function called the Endothelix. It's a very patient-centered, I think, or patient-friendly study in which patients essentially wear a small fingertip temperature probe while a blood pressure cuff inflates and deflates. And when the blood pressure cuff inflates, we're supposed to see a decline in their temperature as the blood vessels constrict. And when the blood pressure cuff deflates, we see a rise in the temperature as the blood vessels dilate. And so seeing good fluctuation in temperature signals good endothelial function via reactive hyperemia. So one of my mentees recently published a study showing that if patients had mildly low levels of thyroid function, they actually had worse endothelial function in a prospective dialysis cohort. By doing patient-centered research in which we collaborate with patients, this has really also shifted the focus of the areas in which I've been studying. And so I would say that the vast majority of my patients, if given the choice of an intervention that can improve the quality of life versus the length of their life, would choose the former. And so we have, therefore been very interested in studying patient-reported outcomes, in our CKD and ESRD patients. So several years ago, we completed a study in which we looked at 450 dialysis patients who underwent prospective thyroid tests, as well as quality of life surveys. And we found that higher TSH levels were associated with worse quality of life, specifically in the domains of energy and fatigue, physical function, and pain. And so if there were any intervention that I could provide to my dialysis patients that could actually improve their physical function and their energy level, it'd be really exciting to see if levothyroxine can actually accomplish this. So based on these observational studies, what can we conclude? It's plausible that thyroid dysfunction could be causally associated with adverse outcomes in kidney disease. It's also plausible that thyroid dysfunction may be a marker of underlying illness, which in and of itself is a risk factor for cardiovascular outcomes, adverse outcomes. It's possible that thyroid dysfunction may be on the causal pathway between underlying illness and adverse outcomes. And it's also possible that in some subpopulations, such as those with malnutrition and protein energy wasting, thyroid dysfunction may not at all be associated with complications. Just gonna pause, please. Okay. So understanding the impact of treatment may potentially glean insights into the causal effects of thyroid status in kidney disease. So United States Renal Data System data is our national registry funded by the US government that examines all dialysis patients in the United States. And it is consistently shown for the past decade that levothyroxine is one of the most commonly prescribed medications in CKD and ESRD patients. So it is the number 4 prescribed medication in non-dialysis dependent CKD patients who are Medicare Part D enrollees. And it is the number 12 medication in ESRD patients who are Medicare Part D enrollees. Now, in the general population, there has been promising data showing that in small clinical trials, levothyroxine can reverse adverse cardiovascular outcomes over a 6 to 12-month period in patients with diastolic dysfunction, dyslipidemia, endothelial dysfunction, and atherosclerosis. But there has actually been fairly sparse data looking at large longitudinal cohorts and even the non-CKD population. But this was a very well-done study conducted by Dr. Rosby et al.'s group in the UK, which showed that thyroid hormone replacement in non-CKD patients with subclinical disease was associated with reduction in cardiovascular events in the younger population, but actually was not associated with benefit in the older population. There has been even more limited data in the CKD and ESRD population, but in a study of over 2,700 dialysis patients, in whom we had both thyroid status and medication data captured, we found that those who were hypothyroid treated to target actually had a similar survival compared to those who were spontaneously euthyroid. However, those who were hypothyroid with or without treatment actually had a higher death risk. We also looked at this in a large cohort of US veterans with stage 3 CKD, and we found that compared to patients who were spontaneously euthyroid, those who were undertreated or untreated had higher death risk, but those who were hypothyroid but treated to target had similar survival. Now, while these limited observational studies suggest possible benefit, we have to keep in mind that levothyroxine can carry potential risk. It has been deemed by the FDA to be a neurotoxic to therapeutic drug, and it can increase protein catabolism, which is a risk factor for death in dialysis patients. Furthermore, patients with CKD who have unwarranted treatment could be vulnerable to adverse effects because of their underlying cardiovascular risk, such as atrial fibrillation and high output heart failure. So we really need clinical trials to inform the efficacy and safety of levothyroxine in CKD and ESRD patients. After presenting a number of observational studies through the years, I was really pushed by a lot of collaborators to pursue a clinical trial. But before we could launch into a large multi-center study, I was very grateful that the NIH gave us an R3 grant to set up a pilot feasibility study. And essentially, the main aim of our initial pilot trial was just to see, does levothyroxine work? When we give levothyroxine to hypothyroid dialysis patients, does it even affect their TSH levels? And in this single center pilot trial, we essentially did find, yes, that compared to placebo, it was more efficacious in achieving target TSH levels. More importantly, this small pilot study also set the infrastructure for a large NIH R1 trial that is currently being conducted by our group at this time. About 3 years ago, we received funding for a multi-center NIH R1 trial in which we are looking at patients randomized to levothyroxine versus placebo, in which our co-primary outcomes are quality of life and coronary artery calcification. We are also looking at a number of secondary and exploratory outcomes, looking at physical function parameters, cardiovascular parameters, as well as metabolic parameters. And it has been a tremendous amount of fun working with different sites, with different experts in endocrinology, nephrology, cardiology, physical function, and exercise physiology. We are about 1/3 of the way through our recruitment right now, despite the pandemic, and we hope to have important findings to report to the community. If you want to learn more about our study or have access to any of these resources that I've shared, we have a website called www.thyroidhd.com. And you can learn more about the research we're doing, and also has my contact information for reaching out if you'd like to pursue any collaborations. And really the overall goals of our NIH Thyroid HD trial are to, number one, to guide the optimal management of dialysis patients with thyroid dysfunction in order to improve their quality of life, their cardiovascular health, and their survival. Essentially, can a very easily accessible medication such as thyroid hormone supplementation actually help our patients feel better and improve their cardiovascular health and their physical parameters? Second, a major goal of our study has been to partner with a community to encourage a diverse representation of dialysis patients to help a broad range of the population we're actually caring for. So we feel and believe strongly in diversity, equity, inclusion. I feel really privileged to live in a very diverse part of the country in Southern California, as is Miami, in which we are able to partner with patients of a diverse background, as many of our dialysis patients and those with thyroid dysfunction are affected by this endocrine complication. So in conclusion, CKD patients have a disproportionately higher prevalence of hypothyroidism, but unfortunately, in many cases may remain latent and undiagnosed. At this time, the thyroid-kidney mechanistic link remains uncertain, but emerging data suggests that this relationship may be bidirectional. Thyroid functional derangements, including hypothyroidism, have been linked with death, cardiovascular disease, and adverse patient-reported outcomes in both the non-CKD and CKD population. And finally, rigorous studies are needed to determine the impact of longitudinal thyroid hormone treatment on kidney disease progression, cardiovascular disease, and mortality in CKD. I would like to pay acknowledgement and my gratitude to so many wonderful mentors and collaborators and mentees through the years in pursuing this area, as well as the NIH, the American Thyroid Association, National Kidney Foundation, and once again to the University of Miami for allowing me to connect with you today. Thank you.
Thank you very much, Dr. Rhee. That was really an exciting presentation, and I think demonstrates the beauty of having large databases to work with. I mean, 4 million individuals, not many of us get that opportunity in any situation. So let me sort of back up a little bit, because the concept of subclinical hypothyroidism, we know that and you use TSH as a surrogate for saying people are hypothyroid, but when we measure the thyroid hormone levels in these individuals, they aren't significantly different. So what evidence do we have that TSH itself, for which there are receptors, in almost all tissues of the body. How do we know that it isn't the TSH itself, and independent of the thyroid action, is actually causing some of these problems?
Thank you for the wonderful question, Dr. Weiss. And I have to say, I have followed your work through the years as a world-renowned leader in thyroid disease, and it's just such a tremendous privilege to connect, with you and your amazing department, in this conference. And I think we don't know, and I think that's a great question. It needs to be further investigated. And if there's any opportunity to connect with experts such as you and others to be able to tease out these important mechanistic underpinnings, I'd be very excited. And I think really the first step, we're even just trying to understand, is there even a causal relationship in all these observational studies, but what are going to be the effects on the cardiovascular and metabolic and physical function parameters in the clinical trial? I think we're hopeful that we see improvement if there is some intervention that can actually help our patients, although it may not, this study, may not provide the adequate information about the underpinnings you've outlined. But I think even if it is negative, it still may actually inform management, because a lot of patients are being treated at this time and we don't know if it's appropriate.
Absolutely. I think that's great. Thank you very much. Dr. Fornoni, your hand is raised.
Yes, thanks, Connie, for the wonderful presentation and very stimulating a lot of discussion opportunities. Now, it's a little bit similar to the question that Dr. Weiss had, but I'm not really sure we discussed what is the tissue distribution of TSH receptor as well as thyroid hormone receptors in the kidney and in the heart. For a person believing that what drives CKD progression is actually the emphatic on the kidney parenchyma, I would love to believe that if there are receptors in my kidney favorite cells, the thyroid hormone stimulation would prevent the emphatic of my kidney cells and maybe prevent disease progression. Do you know what the distribution is?
Yeah, that's a great question. I'm probably not the most expert to be able to say what the distribution of different receptors are, but we've had different discussions about this, through different research meetings. So I've been really grateful to work with thyroid experts at UCLA who've been mentors for about a decade. And especially pre-pandemic, I had the opportunity to attend regular thyroid lab meetings with a group of basic scientists and clinical investigators and epidemiologists, specifically in thyroid disease, which I've learned so much. And so, what I've learned from from these endocrinology and thyroid experts are, we've talked about what is the right metric to measure thyroid function, especially if there may be differential distribution of receptors in different tissues. And still, I've been advised, Dr. Hirschman and others, have advised, really, TSH is a good metric to look at. It's probably the best, I think, universal parameter we have, to find thyroid status, at least in the CKD and ESRD patients. The point about cardiovascular disease is interesting because, my understanding is that, T3 becomes an important focus in the cardiac tissues. And I think there also still remains a lot of debate in the nephrology circles as to, whether we should even use T3 as a parameter to measure thyroid status in this population. I think with the team members and endocrinology and nephrology I've been working with, we don't believe it's an accurate metric of thyroid status, of underlying thyroid pathology, because it's confounded by so many factors. But it's really, I think folks who are experts who believe in the other side, Dr. Zoccali is, I think, one of the folks who's published a lot in thyroid disease, believes that T3 is an important marker because of its effects on the cardiovascular tissues. But I'll pause here and see if any other folks have any feedback on this. But that's a great question.
Well, thank you so much for coming today. And I understand you'll be back tomorrow to speak to the division. And I thank Dr. Roth for inviting such an amazing speaker. And it's our pleasure to host you virtually, and hope we get the opportunity to host you in person very soon. So welcome. And I remind everybody to check the chat for the MOC link, and look forward to seeing everybody next week. Stay safe, test negative.
Thank you so much. Yeah, thank you for the tremendous honor, and every